I'd like to welcome members to this meeting of the Strategic Overview and Scrutiny Committee and to members of the public who are listening in via the Teams webcast. Before I start, I would like to formally welcome Councillor Linda Chatfield to this meeting. Welcome, Linda. We have a busy agenda for this evening's meeting, so firstly to practical matters. We are not expecting a test of the building's fire alarm, so if the fire alarm does sound, could attendees please exit the building via the nearest exit. The rallying point is the rear of the car park. I'd like to remind members of the committee to please raise their hand if they wish to speak and to ensure that their microphone is switched on when not addressing an item for the benefit of the webcast and the recording, and switched off when not. I'll refer to the scrutiny officer from Democratic Services if I need to record a vote on any procedural matters. Thank you. So moving first to apologies. Have we received any apologies?
Thank you, Chair. Yes, apologies have been received from Councillor Ray Payne and from Mr Andreas Menzies.
Thank you. Record of the meeting. This is to confirm the minutes of the Strategic Overview and Scrutiny Committee meeting held on the 17th of October 2024. Does anybody have any amendments they would like to make to the minutes? Councillor Heckles.
Sorry, hello. I wanted to make a small amendment to one of the comments, please, on the minutes. Sorry, forgive me while I just open it up. I wasn't expecting you to be quite so fast, Chair.
Page 11.
So it's on page 11, on the food waste options. It says the introduction of the food waste containers in the small black bins would happen at the same time. Smaller black bins would happen at the same time. I think we sort of discussed, there was a lot of things that were being discussed at the time, but it wasn't sort of set in sand as such. So I had a small suggestion, forgive me for just looking at the suggestion on my phone, of an amendment. So the suggestion could be the introduction of the new food waste service and reduced capacity for residual waste would happen at the same time, either by smaller bins or fewer collections, or we could leave it a bit more vague because I don't think any decision has actually been taken.
Right, well, I'll take advice from the officer as to which would be most appropriate.
Thank you. Can you turn your microphone off, please, Councillor Heckles? Thank you. Yeah, as I say, I spoke with Angela Cullerton regarding your query regarding the minutes, and she gave you the statement that because no decision has as yet been made regarding whether it's going to be smaller bins or fewer collections, she said that it would be okay to amend that statement, the minutes, to incorporate the statement that you said.
Is that agreed?
That's much better. Thank you very much.
Thank you.
Thank you. Yeah, the minutes from last time, this is on page 12, the resolutions. We had A to D. The fourth one, D, it said it was agreed that further information should be presented at a future meeting of the Strategic Overview and Scrutiny Committee so that recommendations could be made to Cabinet when it made a final decision in 2025, especially regarding the 2 weekly or 3 weekly bin collection. It's reported as we agreed that, but I believe that actually it was a recommendation that Scrutiny is presented with further information and considers the options for frequency of collections of residual waste so that recommendation could be made to Cabinet in the future before a final decision is made. So I believe that should be a recommendation rather than being stated as agreed.
And I agree with that, and I confirm that with Councillor Wise. So we'll accept that change. Oh. So I'm told that because it's included in the forward plan, this is not the change that we're talking about is not what was agreed in the minutes, but it is included in the forward plan. So there is not a necessity to change the wording of the minutes as currently drafted.
Sorry, just to clarify, I did raise this a few weeks ago, and recommendations obviously go directly to Cabinet and are reported to Cabinet, which I believe, for those of us who were at the meeting, was the intention behind that statement, that it was a recommendation to Cabinet that scrutiny discusses the frequency and the changes to the residual base bin collection before a final decision is made.
The minutes of the meeting are correct. It was not a recommendation. The committee agreed that they would receive an update. They did not recommend that Cabinet provide them with an update. So the minutes are correct.
Okay, I will let that lie, but I think the point has been made, and I think perhaps in future we could have a bit of clearer guidance on that exact wording at the time, because it was my understanding when I proposed that it was a recommendation. Thank you. Thank
you. So I'll propose that the amendment from Councillor Heckles and the minutes amended thereto. So I am proposing them. Can I have a seconder, please? Thank you, Councillor Stevenson. All those in favour, please raise your hand. All those against? Any abstentions? I think five abstentions. Sorry, actions arising. There were no actions arising from the previous meeting. Declarations of interest, not item 4. Does any member have any interest to be declared this evening? I think that's no. 5. Petitions, deputations and questions. Have we received any petitions, deputations or questions?
Thank you, Chair. Yes, we have received one question from Mr Miles Williamson Noble relating to agenda item 12, which is the Joint Health and Wellbeing Strategy. The deputation has been approved by the Monitoring Officer on behalf of the Chief Executive and has been added to the website and circulated to board members in advance of the meeting. As per Procedure Rule 73, the total time allowed for each questioner, including the response, shall be 5 minutes. These questions shall be asked and answered without discussion.
Thank you, Jane. Good evening, Mr Williamson Noble. Could you come up to the table, please, and read out your question?
Thank you, Mr Chairman. The question relates to agenda item 12, and the answer could be provided as part of the discussion on this item if the Chair wants. Various healthcare policies and plans have been prepared and published by the Integrated Care Board and Rutland County Council for the period up to 2025 or 2027 in some cases. They all contain aims and aspirations with which no one could disagree, and this has been reflected in responses to consultation. A strong underlying principle has been that of care closer to home, but no publicly available documents show what additional services are proposed, nor the substantial underpinning costs in terms of capital, revenue, equipment and staffing. It would appear that care closer to home can only be achieved by additional new funding from the Levelling Up Fund or the SIL, or by diverting resources from the ICB, University Hospitals Leicester, which already overspends substantially, or the LPT over the next few years. To propose new initiatives such as dialysis at home or a significantly enhanced Rutland Memorial Hospital is meaningless without making clear what new or relocated services are proposed, how they are to be resourced, and what other services might have to be cut back or even cancelled to fund this. As you'll be told later, the purpose of public consultation includes to give people a voice and opportunity to influence plans and decisions, inform people how proposals have been developed, describe and explain the proposals and the background to them, seek people's views and understand the impact on them, and give due consideration to responses and feedback. No detailed plan or costings for care closer to home have been provided to the public, and the public's views on relative priorities have not been sought. NHS guidance issued in 2022 on reconciling system and place states that system is required to cost capital and revenue plans at place. Has this been carried out? Perhaps by the Integrated Delivery Group? If not, why not? And if yes, when can we expect to see the plans and figures offered for consultation?
Thank you. Do we have a response for Mr. Williamson-Noble?
Thank you for your question. Can we provide a written response, please, within the timescale of scrutiny, which will go out with the minutes, I understand.
Thank you. Thank you, Mr. Williamson-Noble. You may leave the table. Your name, the text of your question, and a summary of the response shall be recorded in the minutes. We now move to item 6, questions with notice from members. Have we received any questions with notice from members?
None received, Chair.
Thank you. Item 7, notices of motions from members. Have we received any notices of motions from members?
None received, Chair.
And item 8, consideration of any matter referred to the committee in relation to the call-in of a decision. Have we received the call-in of any decision?
None received, Chair.
Thank you. Item 9, scrutiny committee recommendations and outcomes. Full details of the recommendations made by the scrutiny committee regarding the dental services in Rutland and the food waste options and municipal waste management strategy review and responses from Cabinet have been circulated with the agenda. Are there any questions or comments on those? No. Thank you. I would like to draw this item to a close and move on to the next agenda item, 10. And this item is a change from the agenda as published. We have brought forward on the agenda due to commitments of an officer, Kevin Quinn, who's here with us tonight. So we will deal with the corporate performance 6-month progress report 2024-25 as item 10 on the agenda. So we now have report number 118/2024, excuse me, from Councillor Andrew Johnson, Deputy Leader and Portfolio Holder for Governance and Resources, and Kevin Quinn, Head of Corporate Services. Councillor Johnson.
Thank you, Chair. Yes, I'd like to introduce this performance report. It's the latest in a quarterly series of performance reports that we regularly produce. It's the second one for this year, and it follows our redefined corporate strategy, which is simplified and has 4 main priorities: tackling the climate emergency, creating a diverse and sustainable local economy, supporting the most vulnerable, and providing good public services. The quarterly report monitors 61 performance indicators that give insight into areas of high importance, and was presented to the Council's Cabinet at its meeting on the Tuesday, 12th of November. The report indicates that Rutland County Council is meeting or exceeding its targets in more than 2/3 or 70% of the areas where data is available. In most cases where performance is currently below target, the Council has shown an improvement since its last quarterly report in June. There are some examples where the Council's current performance is good. These include the condition of Rutland's A roads has increased and is now at 77% following the Council's most recent highway survey. 100% of all highways defects assessed as being immediate hazard or needing urgent attention have been repaired within 7 days, representing 204 reports repaired within the normal timescales. The percentage of Rutland young people aged 16 to 17 not in education, employment and training remains very low at only 0.3%. 100% of children needing protection have been seen on time, and 100% of people who have used the Council's adult social care services report that these services make them feel safe and secure. In the areas where Rutland County Council's performance is currently off target, the quarterly report gives an explanation as to why and details as to what action is being taken. I would like to commend this report. I don't intend to go into all the detail. It's there to see, and I'd like to conclude by recommending, sorry, I can't recommend, the Cabinet's made that decision. I'd like to conclude by saying I think this corporate report is relevant and it demonstrates success. Thank you.
Thank you. I think there are many positives in the report, and I think the reduction in the number of priorities from 136 to 61 should be welcomed and will improve focus. And I think we also look forward to seeing the improvements in reporting indicated from the introduction of BI. Can I ask 2 questions? The first one relates to the designated schools grant. The increase in the number of EHCPs and the backlog suggests that the financial position can only worsen. Will the Cabinet consider investing in an in-county facility to reduce the annual revenue cost of transportation? Will we deal on that one first?
Yes, thank you. We are looking at the costs of transport for SEND children, and will be investigating every possible route to minimise cost. And I'm sure we'll include the route that you've suggested, Chair.
Thank you. And my second question was, at 2.7, it is indicated that we are reviewing our heritage offer to secure the savings target. How is a reduction in an already modest budget consistent with a focus on tourism as a key part of delivering economic growth?
As you know, Chair, we're looking at the heritage offer as part of the LUF work we're doing, so that will be included in there. We're having to make sure that we trim the budgets in any area that's non-core. So whilst we realise we have objectives, we are trying to focus our funds on the 4 corporate priorities, and we will be taking action where necessary to stimulate the economy.
I'm not sure that actually confirms that we're actually focused on actually delivering economic growth, given that it's considered to be a pillar of achieving that growth.
No, okay. If I didn't say the words, but yes, we are focused on achieving economic growth where possible within the funding that we have available from whatever source.
Thank you. Could I open it up now to questions? Has anybody else got any questions on the performance report? Nope. Oh, Councillor Stevenson.
Where we've, oh, and sorry, first of all, Mr. Quinn, that's a very clear report to read, so thank you for that. Where the targets are off, are the targets right? That sounds a really daft question, but yeah, are the targets the right targets? Are they statutorily set targets? Yeah, thanks.
In answer to your question, we review the targets annually to check that they are within the right areas for us in terms of making sure they're stretched and appropriate. For some of the areas, they are statutory targets. So, for example, our education, health and care plans, they're a statutory target. We're mandated to achieve that in timescale. So they will always remain that case. And we will strive to do the best we can for those targets. What we are doing is undertaking a further review of the performance indicators in this dashboard, because what we want to add is contextual data. So we're looking to, wherever possible, have a national or regional comparator for that indicator. So where we are off target or on target, we can provide that contextual data so you can see how that relates to others. And that is work in progress, and we have made some good progress in that area.
Thank you. Are there any other questions? No. So the committee is recommended to note the progress of the Council against the new Corporate Strategy Delivery Plan and Performance Framework, including the reasons for those areas where performance is below target. I will propose the recommendations. Do I have a seconder, please? Thank you, Councillor Powell. All those in favour, please raise your hand. I think that's unanimous. Thank you. Resolved that the committee has noted the progress of the Council against the new Corporate Strategy Delivery Plan and Performance Framework, including the reasons for those areas where performance is below target. Thank you, and I would like to draw this item to a close. That brings us to item 11, Leicestershire and Rutland Winter Plan for 2024-25. We now have report number 130/2024 from Julia Frake-Harris, LLR Director of Urgent and Emergency Care. Councillor Ellison, as the portfolio holder, would you like to introduce this report? And I believe that Julie Frake-Harris is joining us online.
Sorry about that. So first of three from my area, and we are last to have this, but it has been talked about and been available for a while, and we've brought it to the attention of the committee. Thank you.
Thank you very much for the opportunity, Chair, to come and present and share this paper with you. As our colleague says, this has now been to several other LLR overview and scrutiny committees. This is a difficult winter. I'm not going to suggest that it's not. So we know that our winter plan, our winter assurance could never be more vital to ensure that we have robust services to support the citizens we serve. I know that I will take the paper as read because I know that you will have done that. But if you don't mind, Chair, there's just a few items I'd like to pull out, if that's okay.
Please do.
Thank you. So, notwithstanding the fact that we know this is a difficult winter, and we've already, as we know, our acute provider has called critical incident already in October, which is very early, isn't it? And so therefore we need to think and refine our winter plan with that learning, which I can assure you we have. Our plan is very much focused on what our data and our operational and clinical leaders have said we need to do in order to keep as safe as we can this winter. It focuses very much on making sure we've got care options closest to home, that our vaccination programme is robust as it can be. We know we learn from our Southern Hemisphere colleagues, and we know that our flu vaccine is actually online with the flu that is being experienced this year, as is the COVID vaccine, so therefore also very important. We've also scrutinised our data, I think possibly differently this year. In September, we had a workshop with our key operational and clinical leaders to think about what the footfall profile was really telling us about what our citizens need. And we could see that we needed to enhance both our UTC, our urgent emergency care provision, our frailty provision, our admission avoidance provision, which I can assure you in this plan, as you can see, we have been trying to do. notwithstanding the financial constraints of which we're all working in. You can see that we've also got a very clear and robust approach to escalation and rigour for how do we respond for the demand that we're expecting and experiencing this winter. Even only tonight, we've been in heightened response due to the amount of ambulance conveyances that are coming to the acute hospital. You can see that we go through all of those extra initiatives. We call them SDF funded initiatives that we've put on for this winter. You can see them as high impact interventions in the paper. I'm happy to take questions, Chair, about any of those that are standard and those that are additional. I think what's important to say is that we're continuing to iterate and learn as we go through the current heightened demand at the moment. And in fact, several of these initiatives that we thought we wouldn't bring online until January, we have brought online already in the last few weeks to make sure that we can keep our citizens as safe as possible and to make sure that we're very clear about the fact that any risk is held within NHS clinical providers and not within the patient's domain. That's very clear and our focus with developing this plan. I'm happy to take any questions or go into more detail, Chair.
No, thank you for that. That was a very succinct summary. I've got three fairly general questions. Under the subject of winter planning and mental health, could I ask, are these all new actions for 24-25? And secondly, no mention is made in the paper, that at least that I could see, and I may have missed this, about community facilities. And one of the issues that concerned us last year was the underutilisation of community facilities to support our A&E in our acute hospitals. So that was my first question. Would you like me to repeat?
No, thank you, Chair. Thank you ever so much. So if I take the mental health new activities, yes, we've worked with the voluntary sector across the whole of LLR in a very different way, which I think is really positive. We've also enhanced our mental health expertise at the front door, and particularly the consultant level review of our patients that present in crisis. So yes, absolutely. The mental health initiatives I think are really positive for this winter. And what's exciting, if you share my excitement, I suppose, is the fact that if we are able to prove the benefit of these new initiatives, we have the ability to mainstream our mental health initiatives going forward. So for me, that's particularly positive. Your second question, Chair, I think was around community provision much closer to home, which I totally understand from this board's perspective. And yes, we've made sure that this is not all A&E centric, but we're able to utilise our emission avoidance, our community expertise in a different way to make sure that our patients don't actually have to travel where they don't need to. And therefore, we're very clear about how we can ensure they can actually safely stay at home with community primacy. So I hope that's helpful, Chair.
So that is a change, just to be clear, from last year. I was particularly concerned last year when there were people flowing out of the LRI, and we had places like Maryland Vaz that was underutilised at that time. That steps would be taken in this year to ensure that so you're confirming that. Thank you for that.
Thank you, Chair.
On the immunisation programme, this is a question of, I suppose, clarification. You use the term Health Inequalities Hub. Is this the same as Neighbourhood Teams and Facilities Hubs? Well, let me go on. So we recognise that there's deprivation issues with Leicester City. So although deprivation and lack of access is less of a problem in absolute terms here in Rutland, we do have areas of deprivation, particularly given the rural nature and ageing population. So my question really is, not knowing precisely the difference between these two hubs, what is the approach going to be in Rutland with regard to this principle of neighbourhood or local health hub support? Thank you.
Thank you, Chair. So we've worked through with local PCNs around the best way to deliver locally. So this is not about one size fits all. The vaccination hubs as well, we're able to call on in local areas where there is that link up through. So actually we're able to respond in a responsive way. Sorry, that sounds silly, too many responds and responsiveness. But absolutely, so our vaccination demand, we are able to meet the need across the whole of LLR, and that's very much how we want to approach vaccination. So please be assured that there is enough cover in order to be able to vaccinate our citizens and our people, our staff teams, in order to keep our citizens safe. And we're working that through in a dynamic way.
So it's fairly narrowly drawn for the purposes of this discussion. It's based around the immunisation programme only.
No, absolutely.
Would it be correct to say that? Yes.
Yeah, they're local hubs for the immunisation programme.
Purely
much
for
focused on
immunisation.
that.
Thank you. And my last question is, under the critical incident, and it's really comes back to a comment you made in your summary. Can you tell us what the current position is for ambulance response times for Rutland relative to the city and county? Thank you.
I'm afraid, Chair, that level of detail I will need to go to our EMAS colleagues.
I do understand. If you'd like to come back with that and provide that information to the committee, that would be most helpful. Thank you very much. I'll now open up to questions. Has anybody got any questions for Julie Frake-Harris? Councillor Powell.
Thank you for that presentation and providing the slides. I just want, there's a couple of things just to drill down on. You mentioned, I think I may have got it, that you wanted to make sure that the risk lies with the providers rather than with the patients. I think that's what you said at the end of your presentation. I just wonder if you could explain exactly what that means. And secondly, if you could perhaps give us a bit of a overview for our Rutland residents, what is going to be different this year to last year and what they can expect their actual experience of accessing these services. How I can see obviously all the sort of plans and the work that's been put into it, but actually what will they notice that's any different? Thank you.
Okay, thank you ever so much. A really great question. So we know rurality is a really difficult challenge for particularly for any ambulance provider to respond to. But what we've been able to develop is a full set of same day access hubs and alternatives to ED that our ambulances are able to access very differently this winter. We call them SDECs. And also our healthcare provider ambulance calls, we're able to make sure we reroute all of those calls away from ED. And therefore the speed of response is very different, because actually what we need to do is make sure we keep the maximum number of ambulance crews on the road in order to be able to respond to the rurality challenge. And we hope that is a change that we've managed to put in place this year. So our clinical bed bureau is rerouting ambulances away from the wait in ED in a way, even over the last 6 weeks, that is different to previously. We're doing this as well to enhance the admission avoidance routes as well. even once a citizen and one of our patients that we serve is on the back of an ambulance, to be able to make sure that if there is an alternative community response, even at the last minute, that we're able to get them back there closer to home, because we know that ensures that we enable the maximum number of ambulances to stay on the road, because that will have an impactful impact on our Rutland residents. So that is very much rewired for this winter, and we're seeing the effect of it already, even with this increased pressure, which is unprecedented for this time of year. I hope that starts to unpack the answer that you were after.
Okay, yes, thank you. Are you able to just explain a bit your statement about the risks? And does your answer then mean we should expect reduced waiting times for ambulances?
Yeah, so absolutely. So my absolute commitment with the rest of health and care is that we take the risk into a health or care provider's sphere, and it doesn't stay with the patient with an unmet need, and that's the absolute focus. And with that, it means that we need to make sure we are able to increase the number of ambulances that stay on the road. All the alternatives, as I was saying. So that's what I talk about, making sure that the risk is not left with the patient. It is left with a provider with skill, because that massively reduces our citizens' risk. So the biggest risk is the unknown one that's on our patient's kitchen floor. And that's very clearly where we're focused on making sure that that is the minimum it can be.
Okay, thank you.
Councillor Stevenson.
I'm going for the prize for the most blindingly daft question. We've been mentioning that apparently it's a critical incident in October, and this winter is particularly bad. I didn't know what was, were there any obvious causes for that? And my second question, and you may tell me off, Chair, because I possibly should have declared an interest. I was trying to book a flu vaccination for my son, and I noticed that there were no vaccination centres offered in Rutland. So I was wondering if that could be picked up, please. All of them were Leicestershire, Leicester City. Thank you.
Okay, so if I absolutely take the Rutland local hub action, and I will come back to you. And I'm really sorry about that, because that should not be the case. So please, if we could have a way of communicating, let me take that one up. And then now I can't remember your first question, because I was so focused on how bad that was.
Oh, yeah, as I say, that might be bad luck, and apologies for, because it is a very anecdotal relating to my son. The first one was my daft question, which is, why is this winter so particularly bad compared to other winters? Could it possibly have been predicted, so therefore to avoid critical incidents? And apologies if that really is a daft question.
It could be so least daft that if only we absolutely knew the answer. So, Councillor, it's not daft at all. The demand has been unprecedented. As you know, we cycle in health and care, and we normally have a lull over the summer and the end of the summer period. It feels as though we didn't have that in the same way. I do think that our supporting our primary care, our GP colleagues, to be able to express their right to collective action has started to have a compounding effect, and we wonder whether that's brought a level of winter stress forward. We've been really focused on that in LLR, both to make sure that for planned and unplanned care, that that right isn't bringing forward an increased risk for our patients. So you have to bear with my slightly fluffy response, because we need to continue to work that through as to whether there is a direct correlation. We have absolutely seen an increase in the footfall of patients who interestingly haven't needed a direct intervention from ED. But as I know you will know as a committee, that footfall still needs the respect and validation of an intervention in conversation, and therefore that does take our workforce away from the treating the more acutely unwell patients in ED. So we think that the increase in footfall possibly correlating or having a dual impact with GP collective action has increased that demand much earlier than usual. I think it's also given us the challenge for us to be able to speed up some of our winter initiatives, which is positive and has made an effect. You can see that in the document. So I don't think it's a silly question at all, and that's my personal take on what I think is the compounding reasons for that. I hasten to add we have stepped up a very different LLR response to escalation and oversight, which I think has made sure that we've kept out of that ceiling going forward. Thank you, Councillor and Chair.
Yes, Councillor Stevens.
Sorry, could I make an observation? It's not really a question. There has been a lot of promotion of going to the pharmacist before you go to the doctor, before you trot yourself off to accident and emergency. My observation or my query is, and I do take the point on industrial action and the impact, it clearly isn't working. Because if more people, and you were very, very polite in the way of suggesting that people were trotting and possibly not needing that acute care. So as a general query, does there need to be more work done on residents understanding when they are a medical emergency and when they could actually trot to a pharmacist? Because there's been a lot of push on that. Clearly it's not working.
I think I'm right in saying that there has been more work done on comms this year, particularly in terms of how you actually direct patients who phone up through using 111. Would you like to respond to Councillor Stevenson?
Yeah, thank you, Chair. Councillor Stevenson, yeah, I absolutely agree that we have reconsidered our whole comms strategy, not only to our citizens, but to our other health and care providers around pharmacy first, calling 111 and therefore getting booked into a very large increase in UTC and emergency, I'm sorry, primary care appointments. And I think we have to work with that dynamic of validating our citizens' view that they need something different to pharmacy first or a booked primary care appointment. And I absolutely agree with you, Councillor Stevenson. I think that is still an absolute work in progress for us all to model and to have confidence in the fact that it's only the most acutely unwell who need to be served by an ED department. So I share your observation that that's not working, but I also want to reassure you that we've seen that and we're reworking through our approach to comms. Also to make sure that our DHU colleagues, that our GP colleagues, all of our primary care colleagues are really confident in what that community offer is. It's of incredible high quality. And therefore we need to use it to its maximum. I can also assure you that the extra UTC urgent treatment centre appointments that we've been putting in over the last 6 to 8 weeks have been used. They've also been used by patients presenting at ED, and we're booking them and turning them away, but also by an increased use in 111, which is positive.
Julie, could I just interrupt you there? Deborah Mitchell has joined us at the table to provide some further supporting information to Councillor Stevenson, which may assist in providing a a more comprehensive answer. Deborah?
Thank you, and thank you, Julie. I mean, Julie has covered quite a bit of it, but as part of the work that we are doing on same-day urgent care and the consultation process that you'll hear about later in the meeting, we recognise that we need to work with our populations, and we're going to be doing a specific piece of work in Rutland to simplify and communicate well the different models that there are available, because we recognise the position is very confusing. There is spare capacity in Pharmacy First within Rutland. We don't use it as well as we could do, and more patients could use our UCC stroke minor injuries unit, and we've built in some more capacity in that as part of the changes. So absolutely, we do need to get patients in the right place, and that also will have hopefully a positive effect on primary care, because not all patients need to see a GP, and there are alternatives. And then for those patients that do need to see a GP, we'll be able to free up some of that capacity. Thank you for allowing me to.
Are there any other questions? No, no other questions. So there is no recommendation stated, so I'd like to propose that the committee notes the content of this report. I propose the recommendation. Do I have a seconder? Thank you, Councillor Stevenson. All those in favour, please raise your hand. I believe that's unanimous. So it's resolved that the committee has noted the content of the report. Thank you, Julie, and I'll draw this item to a close now. Thank you very much indeed for your time.
Thank you for your time, councillors.
That brings us to item 12, the Leicestershire and Rutland Suicide Prevention Strategy excuse me, consultation update. And we now have report number 128/2024 from Susan Louise Hope, Strategic Lead, Rutland Commissioning Public Health, together with Mike Sands, and perhaps if you just gave us your name, that might I know you, Mike. So, thank you. Now let me see. Councillor Ellison, would you like to introduce this?
You don't think I'd remember my life. Sorry about that. This has already been discussed and is going through the system. It's been to health and wellbeing, and it will continue to be discussed. But it's an LLR, Leicester City, Leicestershire and Rutland proposal, and a very well written plan, in my opinion. Thank you.
Thank you. Would you like to provide a summary introduction?
Will do. Thank you, Chair, and thank you, Councillor Ellison, for your comments. I'm joined, it's Susan Louise to the left of me, Holly to my right. I shan't burst into song. So the purpose of the report, as the paper says, is to present the draft of the refreshed suicide prevention strategy for Leicester City, Leicestershire and Rutland. It comes to the committee tonight as part of the formal consultation process that we're going through across LNR on the suicide prevention strategy prior to it being hopefully signed off by the three upper tier authorities. It's not the first suicide prevention strategy we've had. It is a national must-do that we have such a strategy, but actually LLR was ahead of the curve in terms of having a suicide prevention strategy which reflects the priority that we give to suicide prevention. And that's basically it, I think, from me. There's an obvious question, I suppose, which I'm sure the committee has got, is why do this on an LLR basis? Obviously, some we do, where we can, we try and make them kind of Rutland specific. It makes sense to have a suicide prevention strategy across LLR for a number of reasons. Most importantly, I think, is to recognise the role of a number of pan-LLR-wide organisations in that, notably the police that we work with very closely in terms of our real-time surveillance monitoring around data. So it makes a lot of sense, but I think it is important that within the context of an LLR strategy that we do have a good understanding of the picture as it relates to Rutland and specific actions that would be specific to the Rutland picture as well. So if I may, Chair, I'll just turn to Holly just to outline the key features, if you like, in the strategy and pick up on the Rutland-specific bits. So, all yours.
Thank you, Mike, and good evening, everyone. As Mike said, I'll pull out some of the key bits from the draft strategy. So, as Mike mentioned, leadership for suicide prevention sits with upper tier local authorities. Leicestershire County Council led on the development of the strategy, which is why I'm here today. But we worked in close collaboration with colleagues in Leicester City Council, Rutland County Council, as well as the ICB, LPT, Leicestershire Police, various voluntary and community sector organisations and experts who have lived experience of suicide as well. The previous strategy, which ran from 2020 to 2023, has given us some good foundations to build from. However, it was in need of a refresh. And although a lot of the priorities remained relevant, we still wanted to have a look at them through the new data lenses and new evidence that is emerging. Achievements from the previous strategy include the delivery and development of the LLR self-harm service, the expansion of the Tomorrow project, which supports those bereaved by suicide, the further development of the Start a Conversation campaign and e-learning, the establishment of mental health friendly places, as well as our suicide lived experience network, and further close working with our Leicestershire Police colleagues on the real-time suspected suicide surveillance data, which is a bit of a mouthful. So from now on, I'll just refer to that as the police data, or the RT-SSSD, as you will see in the draft strategy. However, we want to do more to support people, and we want to make sure that suicide isn't inevitable. So there is an expectation that our local strategy mirrors the national strategy, which is set out in section 2.2 within the report. However, the steering group who oversaw strategy development were really clear and keen to ensure that a local strategy was based on local need and not just on a national strategy. So we were able to utilise our police data and Office for National Statistics data to get a really clear understanding of our local suicides, and also highlight where our gaps in that understanding are. The report and the draft strategy set out the key headlines in respect to the data, so I won't linger on that too much. However, some of the important bits to note are that 3/4 of our suicides are within males, and a large proportion are also within those that have a previous history of self-harm, which is 42%. Rutland numbers are low, meaning they're often suppressed, and rates can't be calculated annually, because some years they do fall below that 5 mark, which is actually quite frequent for Rutland. However, using the police data, we do know that between 2018 and 2023, there were 12 suicides, or 12 suspected suicides within Rutland. As well as the data, our draft strategy was also based on engagement. So we've done quite a lot of engagement with partner organisations and stakeholders, as well as those with lived experience, just to capture their views, and that included young people as well. Utilising the data, the engagement feedback and the latest available evidence, we came up with our 5 key priorities, which cover children and young people, high-risk groups and locations, self-harm, bereavement, as well as leadership. And these will be delivered utilising our guiding principles of co-production, learning from past stories, being data-driven, normalising conversations, so addressing that stigma and the taboo that still surrounds mental health and suicide, using a settings-based approach, and adopting trauma-informed practice. As part of this, we will also be developing an action plan to ensure that we can implement the actions to address the priorities which are outlined within the draft strategy. The action plan will contain actions specific to each area based on the data and the evidence and the local population, and there will be officers representing the areas contributing to the action plan development and delivery. Within paragraph 2.66, it outlines some of the potential activities that might come out of the action plan, and they include incorporating more lived experience voice into the work that we're doing, advancement and more uptake of suicide prevention awareness training, working closer with our private sector and primary care sector colleagues, supporting the implementation of mental health safety planning, with the aim to ensure that everybody recognises that they have a part to play in suicide prevention. Suicide prevention is everybody's business, and that is one of our key messages within the draft strategy. In terms of Rutland-specific elements, and I promise I will finish shortly, although the numbers are low, we do know that they follow kind of the local LLR trends as well as the national trends, with the majority being in males who are single, of white British origin and who are unemployed. The median age of those who take their lives in Rutland is slightly older, but we would expect that due to the demographics. And priority 2 within the strategy aims to focus on high-risk groups, which will encapsulate those working within agricultural and farming industries, those impacted by rural challenges, veterans and those within the armed forces. Actions specific to these groups, as well as Rutland-specific actions, will be highlighted during our action planning processes, of which Rutland officers will be part of. The public consultation opened on the 28th of October and will remain open for 8 weeks until the 22nd of December. It is mainly an online consultation, however, we have been undertaking focus groups and printed copies can be requested as well. And we welcome input from the committee as part of this consultation. Thank you.
Thank you for that most comprehensive summary. And the papers were extremely comprehensive. Could I ask just one question? At 2.6.6, you talk about targeting high-risk groups, such as middle-aged men. At the risk of stating the obvious, this is a very large group. So my question is, will the data exist? And I know you've spoken about your improved data collection methods, to allow you to focus your resources appropriately? Thank you.
Yeah, so if I start, I mean, I'll let to Holly and to Susan Louise on this one. Certainly within the context of the things to do with previous history of having been in contact with primary care, for instance, which might not necessarily be in relation to suicidal ideation or indeed self-harm. It could just be that people have been in contact, middle-aged men have been in contact with health services. That would narrow it down a bit. Then there's always a targeting in terms of manual groups. So we begin to narrow it down. I suppose the question is then, well, how do we know about that? And I suppose that is about the work of things like the real-time data people, in terms of this isn't just looking at ONS style kind of whole population level data over 3 years. It's almost like a case-by-case review of the suicides and attempted suicides or suspected suicides that there are, which we can then feed back into thinking, how do we then target our messages? So it's certainly across an intersection of middle-aged men, previous history, focused on routine and manual groups, begins to chunk it down, and then we can go through it case by case. But I don't know if you two would want to add to that.
Just to say as well that a lot of the work we do is in partnership with other agencies. There is a suicide audit and prevention group which works to address suicide prevention across LLR, and that's quite wide-reaching with a lot of organisations involved. As local authorities, we can't do this alone, so we do work with others who are in contact with other people that we might not always be able to reach well. We do know that there's a lot of the issues around men, and the Samaritans break it down nicely, so I'll just read this out because it sums it up. It's the issues with men, it's around personality traits such as psychiatric illness and mindset, masculinity, so the perception they have to be strong and provide for the family, relationship breakdowns, show themselves worse than men because men generally in middle life tend to rely on women for emotional support. There's the challenges of midlife emotional literacy. Are you making faces?
Do we?
We've done this too many times now. And socio-economic factors. So we know that addressing a lot of those factors will reach men as well as reaching other high-risk groups as well, because suicide is very complex and multifaceted.
So just by way of a follow-up, those all sound, they're all existing organisations that are sort of known to us. So the differences going forward are from the previous strategy.
The previous strategy, I think it's having a much more joined up approach. It's understanding our data better. We have put lots of things in place since the previous strategy, so it's really building on those successes. COVID although it was devastating, did allow us to try new approaches as well, such as the LLR self-harm service, which was managed to retain. So there's a lot of things that we started in the previous strategy that we really want to build on and continue and make stronger and make sure that we can get the messages out further.
Thank you for that. Could I open it up to questioning now? Councillor Carr.
Not necessarily a question, it might be more observations. We do know that getting real-time surveillance is really, really tricky, and often you will get the information quite a lot of months after the suicide has taken place, so that can be a challenge. But also what is a challenge is sometimes about the sort of fundamentals of information sharing, and so I guess my question is around that sort of formalisation of information sharing, because I have sat in many meetings where it has been quite difficult because of information and sharing governance, where partners haven't been forthcoming with the information that would be really helpful. So I'll park that one for a minute because this one's dead quick. You talked about trauma-informed and having trauma-informed services. So is the idea then to ensure that the sort of the frontline staff have had that kind of trauma-informed training and therefore are in a position to be able to support people who, rather than traumatise them again and again and again? So yeah, they're my two things.
Again, I'll start. I mean, again, I looked to Holly on this one. I looked to Susan Louise. I think in terms of real-time surveillance data, I don't want to. I like to feel we've got this one cracked. So, I mean, you're absolutely right. In terms of relying on data that by the time it's been through the coronial process is months down the line, has always been an issue. But in terms of what we get around the table with the police, it is very much contemporaneous, if that's the right word. I was going to say, when we say real time, it's not as if it's urgently, but I mean, you know, it's on a kind of daily stroke weekly basis. There is a risk in that, of course, that you're then getting into land of, well, was this really suicide? Was it suspected suicide? But actually, normally, by and large, what comes out of an understanding within the first few days that's then shared by the police with partners around that table tends to be backed up with what then comes out at the end of it. So from my point of view, I think that's one of the strengths that we've got across LLR. We don't think we've got any issues around data sharing. Police have been really good. We just sit around the table and discuss the case, and that gives us insight months in advance of, you know, waiting for an official verdict, for want of a phrase. But again, Holly, I don't know if you want to build on that and pick up the second bit.
Yep, as Mike said, the data's good. It's taken us a while to get there, but we do have a data sharing agreement in place with the police, and they provide us the data on a frequent basis, and we have a colleague in our business intelligence service that pulls it together into a dashboard for LLR and then presents it on a quarterly basis to the Suicide Audit and Prevention Group. But there is also a weekly meeting that takes place with partners to discuss the suicides real time, so we can understand, we can look for trends, we can look for any kind of suicide contagion that may be occurring. In terms of the trauma-informed question, that is the hope, yes. It came out loud and clear throughout all of the engagement that people were being re-traumatised, often going through services and kind of having to unpack their stories, put them away and bring them back out again. And that's why we put it through as a guiding principle, because we feel it should steer our work moving forwards.
Councillor Powell.
Thank you for that. Yeah, very informative. As a layperson, not knowing all the terminology around this, just quite a simple question, really. Interested, obviously, how you're working with charities, community groups, whatever, who are dealing a lot on the front line. And you're talking about monitoring progress, how you'll monitor progress in an action plan and overall number of suicides. Do you also get data from those organisations, like, you know, obviously anonymised Samaritans and Farming Community Network and those sort of organisations, of numbers of attempted suicides? And is there any monitoring of as a measure of how well these things are working? Does that make sense?
It does make sense, and it's a question we get asked often, and it's one that we don't have an answer for, to be honest. We don't capture attempted suicides. Often when they come through different means and mechanisms, it's how they're coded when they come through the system, and there isn't really a code for attempted suicide. There's a code for intentional self-harm, but there isn't one for attempted suicide, so we're not able to capture that data. But moving forward with self-harm is one of the key priorities. We do want to look at our data monitoring on that and how we can improve that better and respond better to that, so that we can answer that question more thoroughly in the future.
And it's an interesting one, isn't it? Because even if we tightened up the coding, as Holly was saying, coming back to those kind of inequalities or the differences in experience, you know, who would be less likely to go to a GP to say they've had an issue would be the groups that we're trying to target. So there is something about a kind of softer dialogue with, for instance, the farming community. It's almost kind of based around how, you know, it's almost like well-being stuff. How have you been feeling? Have you had suicidal thoughts? You know, because there might be people who are going through a bad spell, but actually you'd rather not wait until they show up as a self-harm or an attempted suicide on a GP record. You would want to know that in advance. And of course, that's really quite soft skill stuff, which maybe we can develop, I think, in the context of the action plan about, you know, it's literally like a temperature check of people's emotional well-being.
Councillor Stevenson.
Thank you. And that sounds really, really encouraging. I was pleased to see reference to the farming community, because I think things will definitely be getting worse in that neck of the wood. I'd just like to pick up on that sort of soft approach, which I think, and that's probably one for you as well, Kim, because you've mentioned contacting RCC officers with the action plan in terms of what does this look like in practice. And it was just to seek assurance that the farming community, and certainly through our officers, that we are talking about that, because I do think your point, people aren't necessarily going to declare suicidal thoughts, particularly if they've got a shotgun licence, for example. They may well be worried that that gets removed, and that actually getting in ahead of time when people are starting to feel wonky and vulnerable, and again, that quite traditional community, we reference sort of men feeling that they should be strong, etc. So maybe some work in schools with those targeted groups, the young boys that hopefully will become farmers, that we really look into that and unpick it before it's too late, because actually once somebody has got to that planning stage, we know it's pretty grim to pull out of that. So if real care and attention can be put to our isolated rural farm communities, that'd be great. Thank you.
Kim?
So yeah, do you want to go first? And then I'll chip. Yeah.
I think that, you know, that's a very good point that you're making there. And one of the things that we need to do is make sure that we're linking into other initiatives that have that kind of early intervention, prevention kind of agenda with people. So programs like, you know, the Make Every Contact Count, mental health friendly places, and, you know, those kind of services that are there to encourage people to sort of have those dialogues, have those conversations, and get into people before or when they're just on the cups of actually, you know, experiencing difficulties. So you can actually have that more of a prevention element and actually getting people before they start to get to the suicidal ideology stage. But also as well, we're aware that there's sort of groups that Rutland have that are, you know, they may not have high numbers, but they're still at-risk groups. As you mentioned, the farming community, and obviously within that farming community, you've got a different group of young farmers that experience a very different kind of issues to generational farmers that have been sort of in the farming industry for, you know, for long periods of time. And I think that we're already sort of making inroads to reach out to those through the various mechanisms that they have, and making links into their groups. And likewise with the military as well, we've already got links into Kendrew Barracks so that we can sort of pick up the military population and also the veterans as well, because that's another key group
for, you know, making sure that we get inroads into those groups, and that's all going to come about as part of the action plan. And we've already started reaching out to the officers within Rutland County Council, because although, you know, I'm a strategic lead for Rutland, I'm not a Rutland County Council employee. So reaching out to the Rutland County Council employees themselves to get them involved into the action planning process, and so that they can bring their expertise and their knowledge of what is already happening in Rutland, so that we can make sure that we link into that. But also as well, we're going to utilise the Staying Healthy Partnership meeting that we've already established for Rutland, because this sits into that agenda perfectly, because it is about enabling people to stay healthy, not just from a physical perspective, but also from the mental health perspective. And I think that that's, again, you've got an issue where many of the people that would be represented in any kind of Rutland-specific group would be the same individuals. So it maximises the best use of people's time to use an existing structure.
I'll just add to that. That's a really comprehensive reply. Thank you, Susan Louise. So part of Rutland County Council, we have a team called RISE, which is the Rutland Integrated Social Empowerment Team that works very closely with the PCN. So they do a lot of preventative work around mental health, working at an MDT level with the community mental health teams and a mental health lead GP. And they are looking at cases and supporting cases preventatively, both on a one-to-one basis at home visits, but also in group sessions. And we have 2 crisis cafes, one in Uppingham, one in Oakham, that are very successful and are well supported by our mental health coordinator. And there's some really good work going on there. Do you want to talk about the healthcare collaborative? Or
well, I need to say, I think, you know, it's in danger that it all comes together quite, it sounds like it comes together seamlessly, and there's always chugs, you know, bumps in the road. But I suppose it's a nice example for me of how we do some things on a kind of LLR basis because it makes sense, because of things like data and numbers, or we might commission a service around bereavement support for those that have experienced a death by suicide. And economies of scale, it kind of makes sense to kind of integrate that way. But when we talk about a Rutland Action Plan, I think through Susan Louise and then what Kim's just said, that's where you get that kind of working across boundaries. So you're not looking at a suicide partnership or this, that, and other. You're working with officers in the council to make those links with organisations like the Armed Forces, and it's like the farming community. So it's almost a nice kind of way of how do you then make suicide prevention everybody's business within the council and within Rutland at that level, and do the things that we have to do in terms of buying stuff and strategic priorities at a vertical level. So hopefully some reassurance that we do talk to each other and we work together as well.
Thank you. Are there any other questions? No? Oh, Stephen.
Potentially a silly question.
Sir Lambert, I beg your pardon.
Thank you. So the Equality Assessment Report mentions the LGBT community being an area that displays, so I get the words, experiences high rates of suicidal behaviour. But there's no mention of it in the report itself at that community. I was looking for some reassurance that there's work in Rutland and LLR to sort of address those areas. From my own lived experience, I know what people go through. Just looking for some reassurance, really, that that's going to be sort of covered by the report.
Yeah, we'll pick that up under the priority 2 high-risk group ones. Yeah, and apologies for the omission of that one.
Any other questions? Are you yes, thank you. So the committee is recommended to note the work undertaken to refresh the LLR suicide prevention strategy and recognises the progress made against the existing LLR suicide prevention strategy. So I will propose those recommendations. Do I have a seconder? Councillor Powell, thank you. So all those in favour, please raise your hand. I believe that's unanimous. So it is resolved that the committee has noted the work undertaken to refresh the LLR suicide prevention strategy, recognised the progress made against the existing LLR suicide prevention strategy. So thank you. And I would like to draw this item to a close. Thanks for your attendance. Does anybody want a break at this time? We've passed the witching hour. No? We're okay. So let's move on to item 13, the Joint Health and Wellbeing Strategy Update. And we now have a short presentation from Kim Sawski, Strategy Director for Adults and Health. Councillor Ellison, as a portfolio holder, would you like to introduce the presentation?
I would, thank you. And look, I've put my microphone on this time without being told. Thank you very much for the third area. This is actually a really good opportunity to review the delivery update and the way forward for the health and wellbeing strategy. There's a lot contained within the slides, but we're going to focus on where are we now, what have we achieved, what the evidence is, what we haven't done, and where we're going. The two particular areas we're going to be looking at are the health and care collaboration, and then specifically the Rutland same-day access, but that's another sort of subsection. So I'm going to pass over to Kim, who is the director for this area. Thank you.
Hi, thank you very much. And so because Chair, you've directed us to keep this PowerPoint to 10 minutes, we will do that. And therefore, we will have to prioritise what we talk about in those 10 minutes. This is an update of the Joint and Health and Wellbeing Strategy. There's a huge amount of information in the PowerPoint. So I hope you'll be able to ask us some questions after the 10 minutes about some of those achievements, some of the impacts that we've made, what's important to you, and also how we communicate to the public. Because of the time limit, we will prioritise on same-day access and that consultation. So I'm going to hand over to Deb Mitchell, ICB lead.
Thank you, Kim, and thank you, Chair. So this links to the item actually quite well on winter. We have, I'm not going to go through all of the slides in detail to keep it brief. This first slide, though, talks you through what primary care does, what our GP practices do, and then gives you a bit of background on the population. Next slide, please. We talked again about pharmacy first and trying to communicate with the public about where you can go. And this slide, and the one that follows it, gives you the conditions, the ones in green, that you can go to your pharmacist for, and you can get those links through. The ones in red are the contraindications, which suggest actually you do need the intervention of either a GP or a different level of care. Thank you. Next slide. And these are the second one is the pharmacy services where they can prescribe. So again, these conditions are where the pharmacist can actually issue a prescription, and the green are the indicators to go to your pharmacy, and the red ones are the indications, the exclusions, where again you would need to seek higher intervention. So put that through just to give you some context of where the same-day access works in the next with the service. So in essence, our same-day access service at the moment is our urgent care centre, which is takes place at Rutland Memorial Hospital, and our minor injuries service. And just from feedback that we've had from the public, from councillors, and from Health Watch, the services are confusing. They happen to be both delivered from the same accommodation, and that accommodation we recognise is old and is in need of an upgrade. And the times that you have an illness or an injury, again, it's confusing about when you can access those services. So we wanted to review that service at Rutland as part of Care Closer to Home. 18 months ago, we introduced extended access to GPs, and we put on some additional evening clinics and Saturday. So that's allowed us, and you'll see from one of the slides, it's allowed us to increase primary care appointments quite significantly in Rutland. But we still have patients who don't necessarily go to the right place because it's difficult for them, and that's one of the things that we want to simplify. So our proposal is that we would join together the minor injuries and minor illness, urgent care centre to a minor injuries and illness service run at the same time. We're proposing that we'll run that for 8 hours a day, 7 days a week. The opening times we are suggesting could be from 1 p.m. through to 9 p.m. and that's just to pick up that evening work, so the evening period for children coming home from school, for example, people coming home from work. But part of our consultation process will be to consult with the public about those opening times. We don't have X-ray 7 days a week in Rutland. We have it on 2 days a week, and we know that that's a gap. I won't pretend that we're flush. The NHS, as you know, is not flush with funding, but we are trying to explore increasing the X-ray provision as part of this review, and we will be having ongoing discussions with providers on how we can do that. A lot of patients go outside of Rutland for X-ray. For example, they go to Stamford or Corby, and as an ICB, we pay for that activity. So if we could provide more activity inside Rutland, then it might help us fund additional X-ray provision. Please. So when Julie Frake-Harris, the director, was talking about the different levels of urgent and emergency care, I think this slide gives you a feel for those different levels and where this service sits. So the bottom tier, tier 0, is your normal GP practice activity, community pharmacy. It would also be some self-care that we would like to encourage the public to have. The tier 1, type 4 activity is the PCN enhanced services. That's the enhanced access I said that we put on 18 months ago. Originally that was meant to replace the urgent care centre, but we wanted to keep it going and do a proper review rather than losing one as we opened the other one. The tier 2 type 3 services, the service that that I'm talking about today, that merged service of minor injuries and minor illness. Tier 3 and type 3 activity are your urgent treatment centres. So they run 24/7. They've got X-ray 24/7, and the nearest ones in the vicinity are Corby, Loughborough and Leicester City. Now, we aren't able to put that level of service in Rutland because of economies of scale, skills and equipment, etc. And then the tier 4 is your A&E departments. Slide, please. Won't go through all of the outcomes, but we know that our public are confused about where to go, and if you go to the wrong place and you go to a higher tiered place, then you're contributing some of those ambulance waiting times, for example, that we talked about by encouraging people to talk before you walk, so that using 111 services or appointment-based services, it will allow us to increase the amount of activity that we put through that urgent care centre, and we've built that into our proposal, and we will. It also means that less people who don't need to be, for example, in an A&E department, need to get there. And if people are ringing for an ambulance for that journey, that adds to that pressure. Next slide. Sue's going to talk you through the consultation process. This is really important for us because we want your input into the public consultation that we're going to do about this service. So just to make sure we are capturing all of the areas. I'm going to hand over to Sue. Thank you.
Hello, everybody. So it's important that with any changes to health services, that the very people that are going to be impacted by those health services, in this case the people of Rutland, are consulted and asked to have their views on those changes, so that we take those views on board. It's also our duty to come to this committee to talk you through the process of the consultation and to hear your views as the experts and the people who know your constituencies far better than we would. So it's important that we have this conversation here this evening with you. If we just go to the next slide, just some of the principles of a consultation, and I hope that some of these, the points that I go through now also help to respond to Mr. Williamson-Noble's questions earlier on. In terms of, we have to be clear what we're consulting on, and we have to make sure that that is simple and clear information is provided. We do have to back that up with the evidence to support. And what we find is that different people want different levels of information. Not everybody wants or hears information in the same way. So the information that Mr. Williams-Noble was referring to, that detailed information around the clinical case for change, the financial case for change, and all that very important detail is put into a public domain for those people who do want that level of detail. But we also totally understand that people might want a summary of information. We provide that in different formats. People just might want some very basic information in a small leaflet or almost a postcard. So we provide the information in different formats to meet all people's needs. It's important to get the questions right. It isn't a referendum. We are reaching out and we're really trying to understand what the experiences of people living in Rutland are, most importantly, what matters most to them. We use a range of ways of participation, and one of the ways that we're doing is utilising a task and finish group, which I'm pleased to say that Councillor Ellison and other members of this committee have agreed to sit on, also along with voluntary and community sector organisations, members of the farming community, army representatives. So we've got a whole range of people. It's really important in terms of voluntary and community because they help us reach out to those with protected characteristics, your most vulnerable residents. And they help us to do that because we don't pretend that we've got the expertise to do that. Proportionate timescale, so as the consultation that we've just heard about in terms of suicide prevention, we are undertaking an 8-week consultation. We also enable alternative suggestions. We don't pretend that we've got the answers right here. We are open to what people are saying, and we report those findings and get an independent analysis and evaluation done, which is presented through to the ICB. If we can just go to the next slide, which I won't go through in detail because, again, kindly Mr. Williamson-Noble has gone through the purpose of a consultation. But bottom line is our role is to reach out to every single member of the Rutland community, those people who are registered with GP practices in this area and others, to understand what matters most to them, and we hope that they participate in the consultation. If we just go to the next slide, reasons for public consultation. I won't go through these in any detail because Deborah's also referenced, but obviously your population is increasing and it is also changing. Access to some services, it can be difficult. It's confusing, as Deb has said. The building needs desperate refurbishment and there is more demand for services. The benefits, or what we believe are the benefits, if we just go to the next slide, is that we believe that we're providing more on-the-day access appointments for those people who really need it, reducing the need for people to drive outside of Rutland, so addressing again what's already been talked about earlier on in the evening in terms of more care closer to where people live. We know the frustrations, and particularly family carers, the frustration of driving, parking at a time when it's they're probably at the end of their tether anyway. Improve facilities for care and treatment, reduces the duplication of services. Hopefully it joins up services. We hear so many times, and I'm sure you hear it from your constituents, why don't you talk to one another, all your services? And also relieve the pressure on accident emergency, which we know is important. Just going to the next slide, many approaches, one size does not fit all. And again, this is where we really want to hear your knowledge, your experience of your constituents in terms of, it will be a strong emphasis on face-to-face. We know digital doesn't work necessarily in Rutland, or whether we will use it, but we won't rely on it. We'll use existing forums. I've already mentioned the voluntary and community. We want to form these strong alliances. You know, we've already had conversations with many people, including Health Watch and the voluntary and community. We want to do more of that. And then also internally staff, social care staff, health staff. If the very people who are providing and talking to the people who are using services don't know about this, then that isn't good. So we want everybody to know it before we go out. And just the next slide for me, continuous conversations in terms of local populations. This is just a few, because we know that people receive different information, so talking to them regardless of age, gender, disability, ethnicity, could be parents, non-parents, living in an urban environment, a very rural environment, which we know is very pertinent to Rutland, users of NHS services, conditions, and many more. Next slide, we want to do continuous monitoring. We don't start it and then just walk away from it and hope for the best. We're continually looking. We know the context of the population before we start. All the way through, we're making sure that we're hearing from true representation of your communities. And we're constantly adjusting when we're going through consultation. So just in terms of next steps and timelines, if we look at the next slide. So we will be starting the consultation on the 13th of January, first task and finish group, with local communities to help design of all of this is the 9th of December, but we'll also be continually talking to those individuals as we go along. So I'll pass back to Deb.
Thank you.
Just one more point, Chair. Sorry. So we are submitting a business case to Rutland County Council as part of match funding from SIL to upgrade the facilities, and that will go through, be submitted in February. We anticipate the new service model and the capital changes upgrades to be completed by April 2026. The service model could be sooner. It depends on the feedback. So the feedback from the public and the changes we need to make. Thank you.
Thank you. Clearly, there has been a great deal of work that's been done, and that's to be welcome. And you set out some clear next steps. And thank you for the detail that you've provided in terms of same-day access. I'm going to make some comments, however, in relation to the presentation as a whole that was in the pack, and these are by way of observations. I think the lack of progress in public communications since October 2023 is not acceptable, and I would suggest to my colleagues in the committee that we should look for an update report early next year on the steps to be taken to remedy that situation. I do think that the use of SAIL and as ICB monies to provide the same-day access through the development of Rutland Memorial Hospital is to be welcomed. However, in the related slides 26 to 34, there is an assumption that people understand that the Rutland Health Plan, the context, which is what we're talking about, that hasn't taken place. So I would personally flag a concern about how this communication might now be best done to meet the timetable, given what we have actually seen in the past 14 months. So I'll open it up now to questions. Are there any questions from any other committee members? Councillor Powell.
Thank you for the present answer. I'm formulating my question as I start to speak. We're obviously concentrating on the same-day access. So just to take it back to basics, because there's obviously a lot of information here. ICB, you've got a proposal. that you're bringing forward, and you've listed out the benefits, which, you know, sound good, because the thing that I pick up from residents, and I'm sure everyone else is there seems to be the barriers to access. It's not knowing where to go, but just not being able to get anything anywhere, going around the houses again, and then not getting anywhere. So I'm really concerned about the people who don't access services just because it's become too difficult, and so therefore they don't bother, and then 2 years down the line they've got a major health problem that could have possibly been prevented. That to me personally is one of the major issues. So what you're proposing sounds good, and the benefits sound good, and presumably costing wise it's doable. It's obviously dependent on the finances being available. And I don't know what, you can't predict that, but obviously there seems to be. So, and I appreciate that, you know, consultation is important, and obviously it's good you've got a task and finish group and all that sort of stuff. A public consultation, I'm just quite interested to know, you can't predict what you'll get back from that, but what tweaks are there that you're expecting? Because I imagine a public consultation will say, we actually would like this facility open from 9 in the morning to 9 at night. And then from a cynical public point of view is, well, I can say that, but that's not going to make any difference. What are you really thinking the difference from the feedback of the public might make? Because we all know that, you know, that what the public wants is a perfect service, and that it's got to be within its boundaries. So I'm just trying to envisage what sort of consultation responses might be helpful to you in shaping it. Does that make sense where I'm sort of coming from? Thank you.
I mean, this consultation does ask some key questions which we generally want to hear the answers to. So you're quite right in terms of opening hours. So we're putting within it a set of opening hours, but we are asking the public in terms of what their thoughts on those opening hours are, and any adjustments that they might seek to propose. Obviously, then we would analyse and evaluate all of those. The aspect in terms of X-ray, we want to understand a little bit more around people using that and people's thoughts about X-ray. So there is a lot that we genuinely want to understand. We also want to understand things like people's perceptions and experience of the pharmacy services. You know, it's a fairly new service that has been introduced. So again, we can make proposals and recommendations on any adjustments to those. So I think from my perspective of all the consultations that I've done, there's slightly more flexibility around genuinely being able to act on what people are saying, and also the fact that we do want to understand what matters most to people. But I'll pass to
Deborah.
If I could add to that. So what I didn't cover, and you know, we're time constrained, and we could talk. There's an awful lot of information, not just on this aspect, but in response to some of the chair's comments. But we had a number of options. We did 2 clinical workshops and with staff, and we involved Health Watch to discuss what our options were going forward. Originally, and you talked about finance, the money that was available that the urgent care centre currently uses, we were instructed from NHS England to reuse those for enhanced access, which we did, but we kept the urgent care centre going, so almost as a double run-in, not double run-in of appointments, but double run-in in terms of resource, because we knew that care closer to home was really important for the Rutland population because of rurality, where you sit on the border, where your nearest services are. So there are a number of options that the public could say to us, actually, no, we want to keep the minor injuries running in the daytime and the urgent care centre running in the evening, that we want to keep it running from the same place, because we're proposing some of the changes in Rutland Memorial. It will still be in Rutland Memorial, but upgrading those facilities Sue mentioned the opening times, but we also want to use the consultation to address some of the other issues around general communication with the public, because we know we have struggled and haven't done well on communication with the public, not least about our health plan, but also about the changes that we are making to services and general services. And that's what part of the information in this presentation is for, but there will be a much broader set of information available for the public. In terms of resources, the cost of our business case is centred around continuing to spend the same amount of money that we do now, but joining the services together and putting talk before you walk and encouraging a more of an appointment service, we will be able to deliver more local activity through that combined service, and by encouraging patients to come to the right place as part of this consultation and communication. And what we haven't said, we will be doing some post consultation communication with the public around the services across urgent emergency care and primary care.
Are there any other? Kim?
I wonder if, Fran, it's worth you talking over the last slide around communication around the joint and health wellbeing plan as well, and how we want to get back on board with that. Thank you.
I might as well do my bit as well, just because I was going to make the same point. There's something for me about it is one thing to consult on a business case for an individual service, but I don't see communication about the health and wellbeing strategy and everything else as being separate. Otherwise, it's very difficult for the public to understand what this will bring, unless it's put in the context of the whole picture. So, I think it's a nice segue into going out. I don't think it's just about a separate comms thing. I almost think it's not a formal consultation, but it has to be engagement with the public about the everything, which then enables a more informed consultation about the individual thing, if you know what I mean.
Thank you. Yes, so I'll just come in then about our commitment in delivering far more robust communication around the delivery of the joint health and wellbeing strategy. So we've committed to ensuring that we have clear communication on the Rutland County Council website by the end of December, which demonstrates at the halfway point of the joint health and wellbeing strategy what we've achieved and what we are still working on achieving. So we have the digital team ready to go, making sure that we're getting an accessible and easy to read document up onto the website that's going to show the actual impact that your constituents will have experienced through the work that we're doing. So that's a commitment that we've assured that we'll make, and also recognising I think we've touched on our kind of comms and engagement function and how we want to build on that and strengthen it. And we work so well as kind of partnerships, different partners. We need to make sure that our comms and engagement function is seamless as well. So that work will be ongoing, and making it stronger.
Thank you, and I'm very pleased to hear that. And I think, in terms of the information, I think time and money are also important factors that actually need to be communicated. When things are going to be done, what money is being invested, and people recognise and value the money that's being invested on. I know that the ICB is contributing money to the same-day access project in capital terms, albeit not in operational terms. Are there any other questions? Councillor Stevenson.
Thank you. Yes, funnily enough, I'd written, is there enough money to do it? But that's already been covered. One of the things that I think will crop up is around the consistency of offer. So residents in different parts of the county have very different experiences, and I'm being very careful, Chair, with how I say this, different experiences accessing GP surgeries. And the other point I'd like to make, which is slightly linking back in to a previous item, it's, I think, understanding perceptions and experiences with that consultation process is really, really, really important. But also it's kind of a two-way traffic in that residents understanding when you actually, what type of service you need. And I appreciate it are harder to reach groups. There's a chance that, so for example, screening is really important, I think, in Rutland, because some of us don't make a fuss and leave us a bit too late equally. So that I would like to see sort of coming through, but that's a two-way traffic of communication and education with our residents, so that the tight resource financial envelope really is hitting the people who absolutely need that at a critical time, which they may have not picked up as being critical. Thank you.
Deborah?
Absolutely agree with what you've said. Just in terms of primary care access, so I think one of our slides suggests it. The number of appointments in primary care has increased. Rutland actually experience higher levels of primary care access than counterparts in city and county, but you're in a different landscape because of rurality. You don't have as many options and choices, so that's why we wanted to continue the service as part of the capital works. And I'm not touched much on them. We will be separating out, as you know, one of our medical practices uses some of that same accommodation that the minor injuries and minor illness service occupy. As part of the capital works, we will be separating it out so that all of that, the current area, will be used for this new service, and then we'll be providing additional rooms for that practice just a little bit further up the corridor on that same side, and then remodelling. We'll also be upgrading some of the accommodation that, for example, community midwives and with some of the maternity services take place. So we have taken account of primary care access. We do know, with the amount of housing growth that we're going to be expecting, and also with the increase in armed forces that we are likely to have, that the continual evaluation of our population needs and primary care access is there. And I've already started some early conversations with our strategy department and primary care to try and plan it ahead for those. But we need the housing numbers confirmed, for example, and we need some stronger plans from the armed forces to be able to take account of that. Thanks.
Councillor Stevenson.
Sorry, I've just circled it. Will we get enough staff? Because I know it can be quite hard to recruit to rural areas, and I was cynically wondering if 2 days of X-ray was because we couldn't actually get radiologists for 5 or 7, and that might be flippant, but do you think to deliver that we will be able to recruit the sufficient expertise and staffing to our very beautiful county?
So I'll take that in two parts. I'll take the X-ray bit second, because that is more complex. But the service that we are looking at in terms of the same day access, minor illness, minor injury service, we will be working to get a provider for. There will be enough staff. The same amount of staff that we are using now will deliver more appointments by the change in model. So I'm not concerned about that element. With regards to X-ray, it is more complicated. So staffing, they are a more specialised group. We do have a funding issue to be able to take account of increase in X-ray, and like I said, a lot of our residents choose to go over the border, and patients' choice is a really important factor for us. It's very hard for us to predict how many residents would come into Rutland to have their X-ray rather than going outside, because there's only one pot of money. But that's one of the things we'd like to explore as part of the consultation exercise.
Sorry, just on the X-ray, because I don't think an under 5-year-old can get X-rayed in this county. We have to go out. Is that correct still?
Again, it's because of the clinical expertise, and the numbers are so small, it would be very difficult to put that in place. It's part of the inconsistent offer.
Mike.
Yeah, thank you, Chair. Just to go back to the bit about screening and stoicism, if you like. Again, I think it's a slightly different conversation from a consultation about same-day access, and again, on a broader presentation, we kind of covered it. I think it's one thing we can pick up through, the High Five project, which started with Mitch and the team working in Greetham around kind of community-led approaches to health. Now, that's very much about generating or linking up the community with each other so they can build their own capacity to support themselves. But actually, I wonder if that's also a vehicle to almost kind of say, look, stoicism and resilience is absolutely where we need to be. Support yourself, support your communities, but there is a limit, and actually it's knowing when to then go, don't suffer in silence and come forward. So I think it's a fair point, but actually maybe that's one we can build into those community-led approaches, almost as a flip side to kind of saying, don't come near us. Unless it's an emergency, we also need to say, don't wait until it's too late.
Councillor Heckles.
Just a quick couple of things. I would quite like to see a nurse practitioner sort of service running so that they could take the pressure off the GPs, and more minor issues they can go direct to there and then be referred on to the GPs at this hub. You're going to do a consultation with residents. I'm very conscious that a lot of my residents don't have computers, don't have mobile phones. I'd very much like, or they don't access the Rutland County Council website. I'd very, very much like to see these questionnaires put into the GP practices, and maybe sort of within parishes for there to be some sort of access.
I think just respond to that. Yes, I mean, we're very well aware that our concentration has got to be on face-to-face, hard copy materials, and less so about digital. So we will be doing print runs of the different formats of documents that I mentioned, and we will be utilising all the outlets. I mean, in other areas that we've done this, we did a very successful one down in Lutterworth, got them into pub outlets, into supermarkets, all of those sorts of places. But this is where we need the expertise of the Task and Finish group, because that group will know, because of your local knowledge, the right places to put stuff, where there's footfall or people going to clear. So no, really good point, and thank you for emphasising it.
Thank you. So just before we draw the item to a close, I suggested at the beginning that we request an update on the status of the communications plan presented at Health and Wellbeing in October 2023. Prior to our March 2025 meeting. Is that something that we wish to have as a committee? Is that an idea that people are supportive of? Yes? Right. So then I would therefore like to thank Diane and the team from the ICB for attending this evening, and I'll now I'm told that you need to formally agree that. So all those in favour of that recommendation that we request an update on the status of the communication plan prior to our March meeting, please, can I have a seconder for that proposal? Thank you, Councillor Stevenson. All those in favour? Thank you. I believe that's unanimous. Thank you for attending this evening, and we will now draw this matter to a close. Thank you once again. Could I now ask for a short adjournment or comfort break? 3 minutes. Thank you. Are you ready? So we return to item 14, review of the work plan. The Scrutiny Committee is responsible for determining its own work programme, so you must use the forward plan, the corporate strategy delivery plan and the contracts register to carefully consider which items to scrutinise during 2024-25. Items must be prioritised to ensure that the scrutiny process adds value and drives improvement. Using the paper process detailed on the pending items list, the committee must agree if the item should be added to its work plan and if so, at what meeting. Does anybody have any questions or comments on the work plan? No. Thank you. I'll now move to item 15, group and panel updates, the Housing Association Evidence Panel. We now have updates regarding the committee's evidence panels. Firstly, we have a verbal update from Councillor Powell regarding the Housing Association's evidence panel. Councillor Powell.
Thank you. A quick update, but actually quite a lot of work gone on already since the scope of this evidence panel was approved at the last scrutiny meeting. I think I mentioned last time that we actually have written to all the housing associations with properties in Rutland, asking for their engagement, setting out what we're planning to do and hoping that they'll engage with us and give us details of any residents associations, etc. We've also met to finalise a questionnaire for residents. We say residents, we started calling the questionnaire a questionnaire for tenants of housing associations, but we changed that to it'll be a questionnaire for people living in housing association properties, because there might be one tenant and a family living there, so it's anybody living in those properties. We have another meeting with, and thank you particularly to Councillor Heckles, who did a lot of the groundwork in researching other authorities who'd done useful questionnaires that we could actually utilise. So we worked through that. When we've had one meeting with the comms officer at Rutland County Council, talked through the questionnaire, made amendments, and thanks to the officers who participated in that. And we've got a meeting on the 16th of December where we will finalise, hopefully, the communications plan and the questionnaire and the means by which it will be distributed, which we will hope to run from the end of January for about 4 to 6 weeks. We've already got a lot of places where we can actually focus on distributing the questionnaire, and we will be talking to councillors as well, because it is a very targeted audience. And then we will have a panel with the housing associations when we've prepared a report. So yes, so we're on track, because we'd like to bring the final report back to scrutiny, I think, in May next year.
Excellent. Any questions for Councillor Powell? Thank you, Councillor Powell. That brings us to item B, flooding evidence panel. We now have a verbal update from Councillor Stevenson regarding the flooding evidence panel.
Thank you very much, Chair. Obviously, we're aware that the final report went to full council on the 21st of this month and was approved, which is great. But what I just wanted to say, and I'm looking over at our lovely scrutiny officer, we have had a meeting with Chief Exec, Monitoring Officer and all members who were involved with that panel, some of whom don't sit on scrutiny but are other members. And that was with the intention of reflecting on the sort of methodology, the process of having an evidence panel. We are used to task and finish groups in Rutland, and so we thought it'd be a very useful sort of what worked well, what could be improved upon for the future, and was it a good piece of kit, in inverted commas. There will be notes coming out from that meeting for us to consider as a scrutiny panel, not for us to consider as a scrutiny panel at all. I was just checking the scrutiny officer was on the ball there, but hopefully it will be then a useful thing for future evidence panels to use so that we become more and more effective in terms of how we do our scrutiny and the value we add to the work of the council. Thank you, Chair.
No, I reciprocate those sentiments. I think it was a worthwhile session. Are there any questions for Councillor Stevenson? Councillor Powell, I beg your pardon.
Sorry, not a question for Councillor Stevenson. I was just going to come in on another point on the verbal updates on evidence panels, but there might be a question first. We have got an asset task and finish group that is, as I understand it, still live. We agreed the scope some time ago. And I know Councillor Payne, who doesn't sit on this committee, and myself have had a couple of meetings. We agreed the scope last year, and no work was done under the scope because it wasn't appropriate at the time. We have had a follow-up meeting and we're waiting for information, but because this is such a while since that's original scope, and members of the scrutiny have changed. I would like to propose actually that the current task and finish group as it stands is put to one side, and that we put forward a new proposal for an asset task and finish group that will actually be able to start and finish. So I'd like to propose, if I may, rather than have this ongoing asset task and finish group in the background that actually is reporting that it's still unable to do any work, that actually it might be timely to
park it,
complete it as not having been able to do anything for various reasons, and actually reinvigorate and revise a new proposal about what an asset task and finish group might usefully do from scrutiny. And proposals have changed as well along the way. I think that's the other thing. It's a moving feast about what has actually changed. So I would suggest that we perhaps say part that one and start again with a new scope. May I propose that?
I think that's perfectly reasonable. Can I ask if you have any indication as to timing in terms of when the work might possibly start, or is that still somewhat vague?
I don't, because further to our meeting with the interim head of property services, we requested some information. I understand that the process is still being going through, so haven't actually received anything at the moment. So I don't know on the timing, and I think that that's an important thing to consider when we bring a scope back to this committee.
That's fine. I look to the officer for the procedure. I agree with the suggestion from Councillor Powell. It seems eminently sensible, but I need to be guided on the exact. If I can then propose that the current task and finish group be stood down, and that we recommission a new task and finish group when the timing of work has actually been more clearly defined. So that's the proposal. Can I have a seconder? I'll take Councillor Stevenson, who's quicker on the draw. All those in favour? I believe that that's unanimous. Sorry, is that unanimous? Thank you. Sorry, Councillor Powell, I beg your pardon.
Could I just make one other point, is that can we ensure that it is somewhere on the work plan for future consideration so that we don't lose track of it? Thank you.
Thank you. That brings us to item 16, any urgent business. I have not been made aware of any urgent business for consideration. Jane, I take it.
No, we haven't received anything, Chair.
Thank you. The date of the next meeting will be held on Thursday, the 19th of December at 7 p.m. in the Council Chamber. I declare this meeting closed at 9:07. Thank you.